Okay, guys, welcome back. And yes, let's go. Once again, I feel that audio video is fine. So let's now get on to our third and the final session for this. And in this session, we'll be taking care of the topics from the limb part. As I told you earlier, that you have the question answer session coming up with Dr. Nikhil. And the things which are like in between the question, there are certain topics which can be covered just with the question only, so we can take care of that here. So let me just quickly go through the upper limb topics which were asked in the last few years, and then based on that we will plan our discussion. See, if you look at the question asked here, there was a question asked about muscle originated from medial epicondyle, and I saw this question asked twice after 2019. उससे पहले भी आया होगा टाइम, but after 2019 twice this question is asked about the muscle attached to medial epicondyle. So muscle attached to medial epicondyle, lateral epicondyle, greater tubercle, lesser tubercle, these bony prominences are important because you may get a question on common flexor origin, common extensor origin that ways. Again, a question asked more than once is the inferior angle of the scapula, and I'll tell you a little tricky part about that. Another osteology question is about the relations of the humerus and different nerves. And humerus is one bone which is having a direct relation to multiple nerves: axillary, radial nerve, median nerve, ulnar nerve. So we got to know about the relations of the humerus and the nerve, so that we know that fracture of which part of the bone can lead to involvement of which of the following nerve here. There was a question I saw which was about the formation of the wrist joint. These are the usual osteology question which I've seen in the past few years, and I'll plan to discuss around them. Another question which is asked like n number of times, snuff box. For some reason I've seen that snuff box is something which is asked as an image based, non-image based. So snuff box, I have to discuss that because this question is being asked over and over again. There are certain questions which are about the dislocations and fractures which can be covered must have been covered in the orthopedic part as well. But there are questions like, there is a question about the upper lateral cutaneous nerve of arm. There's a question about the hypothenar wasting, which is and loss of sensation on medial side of the one of the heart digit here. There's a question about the muscle involvement, the adduction of the arm flexion and the medial rotation. Biceps brachii muscle function is also asked. Pronated teres syndrome is asked. So basically knowing the muscle, some of the major muscle, their action, and if a muscle is giving passage to any nerve, that automatically becomes very important. So musculocutaneous nerve, radial nerve, ulnar nerve, median nerve, guys, the major nerves, they're all passing through some muscle only. So you have to know about that, what muscle is that, and I will be discussing that part with you primarily. There's a question asked about the axilla, the contents of axilla also, and it was a transverse section based question. Winging of scapula is a simple question. I'm sure everyone knows the answer to the winging of scapula is because of what now, but I'll still tell you something in this question. What is the supraspinatus muscle was asked. It was about the supraspinatus tendon. And again, look at the ulnar claw hand, carpal tunnel, axillary artery. Basically, nothing out of the blue in upper limb and lower limb. Like unlike embryology or head and neck and neuroanatomy, they might ask you a question which like a little off the road, off the line. But upper limb, lower limb questions are like the axillary artery, the branches of axillary artery, the nerves, something which you just cannot miss out on: radial nerve, ulnar nerve, median nerve, musculocutaneous nerve, and their injuries. You have to know about this: snuff box and axilla. So I feel that these are the topic which we need to mainly cover up, because we are very likely to get a question from this part here. So this is what my plan is to cover up. So we'll pay more attention to the upper limb part. Compared to the lower limb, guys, lower limb maybe, obviously lower limb is important as well, but lower limb, if you look at the question, osteology based question is asked on the trochanter, lesser trochanter, although greater trochanter is also important. So lesser trochanter question, ASIS question, anterior superior iliac spine question is there. There was one of the question asked about the tendon identification on the dorsum of foot, extensor hallucis longus tendon it was. Navicular bone identification. So most of the questions that I have seen on the lower limb, the osteology based questions are pretty simple actually. Compared to the upper limb, lower limb questions, osteology questions are more simpler. Trendelenburg gait, Trendelenburg sign and gait question, sciatic nerve injury question, okay, and Caesarean gait. So iliotibial band. So again, lower limb questions, comparatively we have more number of questions asked from the upper limb than the lower limb, and that is mainly because of the nerve and nerve injuries here. So you might say that these questions are mainly from the ortho part, but I would still want to cover up that portion because that is where the fair chances of the question to be asked from is there. So how about we start with the upper limb first, and I'm going to go a little with the osteology, guys, in this. Now something that I can mark here in the image itself. See, medial epicondyle and lateral epicondyle. Let me start with that. If you look at the lower end of the humerus, lateral epicondyle, and let's say there's a medial epicondyle. Medial epicondyle, guys, it is a common flexor origin. Medial epicondyle, it's the common flexor origin, and when I say common flexor origin, it is giving origin to the superficial flexors of the forearm, not to the deep one, to the superficial flexors of the forearm. They just, approximately 1 hour, 1.5 hours, I would say. Common flexor origin, and common flexor origin means it is giving origin to the muscles like pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris, and flexor digitorum superficialis. All of them are superficial muscles only. So these are the superficial flexors of the forearm, and they are all having some attachment to the medial epicondyle. They may have attachment to other places also, but medial epicondyle is giving attachment to all these places. That is to the pronator teres, flexor carpi radialis, palmaris longus, flexor carpi ulnaris, flexor digitorum superficialis. And any inflammation or injury to the medial epicondyle, well, that can lead to the golfer's elbow. That is golfer's elbow. On the other hand, lateral epicondyle, guys, lateral epicondyle is for the common extensor origin. It's common extensor origin, and again in the common extensor origin, it's mainly the superficial muscle that are basically coming from here. Now the muscle which are coming from lateral epicondyle, like muscle includes, like we have extensor carpi radialis brevis. There's a muscle called as extensor digitorum. There's a muscle coming from the back of the lateral epicondyle, that is anconius muscle is there. Muscle like extensor carpi ulnaris. So like these, all the superficial muscles again. Superficial muscle of the back of the forearm, they are again coming from that. The name of the muscle is not important. You need to know that it is a common extensor origin. Most of the superficial extensors are coming from there. And the thing here is that if there is a lateral epicondyle injury, or there is an inflammation of the tendons attached to lateral epicondyle, that you all know is called as a tennis elbow. That is a tennis elbow. The great Sachin Tendulkar suffered tennis elbow because of the common extensor origin. The muscle tendon which are attached here, they can get avulsed. Right, so this is about the medial and lateral epicondyle. But because we're sticking to this a little osteology part here, medial lateral epicondyle, guys, if you look at the upper end of the humerus, see again, if you're writing with me and you're not able to write it, just don't worry about it. As I said, after this session, immediately after this session, I'm going to make a PDF and we'll share the link in all the 3 videos that is there on the YouTube. So on all the 3 videos, I'll make sure that I'll put the link of this PDF and you can download it from there, and then you can use it for revision. So here we go, guys. Let's say this is the humerus, and here we have the greater tubercle, which is more toward the lateral side. And here is the lesser tubercle, which is more toward the anterior side. So that's a greater tubercle toward the lateral side, lesser tubercle toward the anterior side. And between them, we have this groove, which is called as a bicipital groove. So a little on the osteology discussion part here, that the greater tubercle is giving insertion to 3 muscle in the sequence of SIT, S-I-T, where S is for the supraspinatus muscle. I should tell you the action also, 0 to 15 degree of abduction, guys. Initiation of abduction is done by the supraspinatus. I is for the infraspinatus. And T is for the teres minor. Infraspinatus and teres minor are more horizontally running muscle, and these are the 2 external rotator at the shoulder. They help in the external rotation, or you can say the lateral rotation, external rotation or lateral rotation to be seen. That is done by these 2 muscles. So 3 muscle attached to the greater tubercle. Lesser tubercle is giving attachment to this big muscle here that is in front, that is a subscapularis muscle. the muscle attached here is subscapularis, and subscapularis muscle is known mainly for the internal rotation. It helps in adduction also, but mainly for the internal rotation of shoulder, that is for the subscapularis. So you're looking at the rotator cuff muscle. So rotator cuff muscle mein, this was the greater tubercle, guys. If I'm writing GT over there, that is a greater tubercle, and this is a lesser tubercle. 3 muscle on greater tubercle and 1 muscle on the lesser tubercle. In between them, we have what groove? Bicipital groove. Now, the name says it all. Bicipital groove is giving passage to the long head of the biceps brachii. And this long head of the biceps brachii kept in its position by the ligament which is covering up, this ligament which is stretching between the greater and lesser tubercle, guys. It is called as the transverse humeral ligament. This basically is a ligament which doesn't allow the long head of biceps to come out. Let me write that for you. This here is the long head of biceps brachii. It's the long head of the biceps brachii, and it is covered by the ligament which is called as a transverse humeral ligament. It's a ligament stretching between the greater tubercle and tubercle, transverse humeral ligament. This is basically keeping the long head of the biceps inside this bicipital groove. Otherwise, when you do the abduction, internal rotation, this long head of the biceps can come out of the bicipital groove. So keep it inside the bicipital groove. We have this long head of the biceps brachii, which is covered by the ligament called as the transverse humeral ligament. Still going with the osteology part, guys, there is a question which is about the nerve. I said that there's a question asked about the nerve and related to the humerus. So if I may just once again draw the humerus for you guys. This is the humerus here. Here is the greater tubercle, the surgical neck, shaft, medial epicondyle, and there's a lateral epicondyle, right? Okay, so in the humerus, guys, when you look at the relation, let's presume that you're looking at it from the front here. So the nerve that you will see in the relation, like the nerve that you will see first of all running behind the surgical neck of humerus, that is the axillary nerve. So it's the axillary nerve which is running behind the surgical neck of humerus. So this nerve can get injured in the fracture of surgical neck of humerus. Fracture of the surgical neck of the humerus, the nerve which can get involved is the axillary nerve, because that is in the relation. The second important relation that you will see is the nerve which is running posteriorly and running in the radial groove or so-called spiral groove, guys. There's a groove which is behind the humerus called as the radial groove or spiral groove. And this is the radial nerve. Radial nerve is present in the spiral groove, and it's the mid-shaft fracture. Mid-shaft fracture of the humerus, which most commonly is likely to involve this radial nerve. Then, if there is a fracture in this region, guys, that is the supracondylar fracture. If there is a supracondylar fracture, well, in case of supracondylar fracture, the nerve which is most likely to get involved is actually anterior interosseous nerve, which is a branch of median nerve. Anterior interosseous nerve, which is a branch of, guys, anterior interosseous nerve is present in the forearm, but in the supracondylar fracture, there is a pull to the anterior interosseous nerve. So the most commonly injured nerve in the supracondylar fracture is the anterior interosseous nerve. Anterior interosseous nerve is always your better answer than the main median nerve. अगर दोनों ऑप्शन में दिया हुआ है तो go with the anterior interosseous nerve as a better answer. Then obviously it is a lateral epicondyle, and here is the medial epicondyle. Well, the nerve that you see which is running behind medial epicondyle and obviously can be involved in the medial epicondylar fracture is the ulnar nerve. So no doubt about that. Ulnar nerve is the one which is commonly involved in the medial epicondylar fracture. But when it is a lateral epicondylar fracture, now that's interesting, guys. In case of lateral epicondylar fracture, the most commonly affected nerve is still the ulnar nerve, and we call it a tardy ulnar nerve palsy. Tardy ulnar nerve palsy, guys. There is a tardy ulnar nerve palsy. Now, what is a tardy ulnar nerve palsy? That if the lateral epicondylar fracture is there, then this angle between the arm and the forearm will increase like this. It will increase toward the lateral side, isn't it? If there's a fracture here on the lateral epicondyle, the angle between the arm and the forearm will increase, and that will put a stretch on the medial side. So fracture lateral side पे हुआ है, but because of the increase in this angle, so there is a stretch on the medial side and there is a stretch injury to the ulnar nerve called as the tardy ulnar nerve palsy. So whether it is medial epicondyle or lateral epicondylar fracture, ulnar nerve is most commonly affected in both the cases. Ulnar nerve is most commonly affected in both the cases. In both the cases. Okay. So this is about the few things about the osteology, the first few questions you're looking at here. Guys, inferior angle of the scapula, there was a question asked here. Inferior angle of scapula is present, either you say it is present at the T8 level, or you can say, a different way of saying is at the spine of T7. At the spine of T7. Because here, if this is a T7 vertebrae and that is a T8 vertebrae, this is T7 and that is T8. So T7 का बेटा spine ऐसे आएगा. The T7 spine will be like this here. So either you say the spine of T7 or you say the T8 vertebrae, that is the inferior angle of scapula. So be careful in the option कि vertebra दिया हुआ है, spine of vertebra दिया हुआ है. So body of vertebra दिया है, spine दिया हुआ है. Body of T8 vertebra, but the spine of T7. That's where the inferior angle of scapula is present. Yeah. Bone not forming the wrist joint. Again, you will be discussing it with Dr. Nikhil in the question, guys. Wrist joint की formation में we need the radius. We need scaphoid and we need lunate. That's it. It's a radiocarpal joint. When I say the wrist joint, it's a radiocarpal joint, and radiocarpal joint with wrist, we have this above, we have the radius bone, and radius bone is articulating with the scaphoid and the lunate, right? So ulna, and it's not participating in the wrist joint. There's something called as a wrist joint complex. That's a different story. But in the wrist joint, radius bone, scaphoid and lunate are required for this here. Coming to the question on the snuff box here. I'll tell you more about the other things as well. But the question on the snuff box. Guys, for the snuff box, again, I need to draw it for you. For the snuff box, let's put it this way. Well, let's say if this here is the hand, so here is a thumb, and let's say this is the index finger and all that. We don't have to draw the entire hand. If I just draw a small part of it. Here's a thumb. Okay, so the tendon which are forming the lateral boundary of the snuff box. So in the lateral boundary, because this question is asked with a real-time picture, they will give you the picture of the hand and they will show you the tendon on that. You just have to imagine that what tendon is most laterally placed. So most laterally placed tendon is a tendon of abductor pollicis longus, and then we have extensor pollicis brevis, and then the medial boundary of the snuff box is by the another tendon, that is a tendon of extensor pollicis longus. Sequencing is important, guys. If this is the lateral side of this picture, thumb obviously is toward the lateral side, and that is the medial side of this image. So when we talk about the lateral medial boundary, the tendon that you see first of all, that is that is an abductor pollicis longus tendon. Abductor pollicis longus. Along with the extensor pollicis brevis. That's the whole idea. Extensor pollicis brevis. So in the lateral boundary, so if you see the tendon present toward the lateral side, अगर आपको snuff box का picture दिखाई दे रहा है, you're looking at the picture of a snuff box. Lateral side where the two tendons will be visible to you. The outermost tendon will be the abductor pollicis longus, and slightly inside will be the extensor pollicis brevis. So when I extend my arm like this, thumb like this, so though my snuff box is not very well visible, but still if I say like if I extend my thumb, maybe a more leaner person than me will be able to see this. So the tendon which will be like more toward this side, more toward the radial border, that will be these two tendons. If I go more toward the inside, toward the hand side, that's toward the medial side, that will be a tendon of extensor pollicis longus tendon will be there toward the medial side. Extensor pollicis longus tendon is forming the medial boundary. But that is not it, guys. That is not it. There are other questions on the snuff box also. It's just not about the boundary only. In the anatomical snuff box, well, we all know the content here. Everyone knows content. Whether there is no issue, there is obviously the radial artery inside. Content is the radial artery, so that is there is nothing to ask as from the content point of view. Radial artery is the content surely, right? The question is about the floor and the roof. The floor and the roof. Let me go with the roof first. The roof of the anatomical snuff box. Like roof of any place, guys, we have skin, superficial fascia, all these things are there. यहाँ पर भी होंगे skin, superficial fascia. But the two important structures which are present in the roof, one is the cephalic vein, and there's a nerve here. That what nerve is that? Which is superficial branch of radial nerve. I hope you know the contents of cubital fossa, MBBS or MBBR, whatever you say. S is a superficial branch of radial nerve. So it's the superficial branch of radial nerve which ultimately goes into the roof of snuff box. Superficial branch of radial nerve. Superficial branch of radial nerve. And this is where, Ashima, I want to tell you this thing. When it comes to the floor of this anatomical snuff box, then it is not just by the scaphoid and trapezium. There are in the anatomical snuff box, there are 4 bones actually which are present. Now, starting from the radial style, if I look at the bones on the lateral side, so it's a radial styloid process, then we have scaphoid, then we have trapezium, and even the base of first metacarpal. Charo ki charo bone present hai, and even there are 2 tendons inside the floor. So when it comes to the detailed floor of the anatomical snuff box, there is the radial styloid process. Radial styloid is there. Then you rightly said there is a scaphoid. Next to the scaphoid is the next carpal bone, that is trapezium, and even the base of first metacarpal. Base of first metacarpal is also there. But yeah, you rightly said that trapezium and scaphoid bone are the 2 major bone present inside. Especially scaphoid is given very much emphasis on because scaphoid is the most commonly fractured carpal bone. Falling on the outstretched hand, scaphoid bone can get fractured. And if there is a scaphoid fracture, there will be tenderness in the anatomical snuff box. Remember that scaphoid fracture will be there. It is a main bone present in the floor of the snuff box. So there will be tenderness in the floor of the snuff box if there is the scaphoid fracture. The interesting part is, apart from these 4 bones, there are 2 tendons also. There is ECRL and ECRB. Extensor carpi radialis longus and extensor carpi radialis brevis tendons are also passing through the floor. So the floor is not just by the bones, it is by the 2 tendons also which are present inside the floor. I don't have to draw it, but the 2 tendons are also there. That is ECRL and ECRB tendons are also present. Yeah. So this is about the snuff box here, because this question is asked so many times that it makes sense that you need to know about all details of this. Boundary you should know, you should be able to identify the boundary. Content is radial artery, no problem with that. Roof mein cephalic vein, superficial branch of radial nerve. Floor may need to know all the 4 bones present, most importantly scaphoid of course, and the 2 tendons in the floor, so that if they repeat the question on the snuff box, even if they ask like little beyond the usual thing they ask, they should be able to answer this question. Okay. Chali, let's now invest some time in understanding the nerves of the upper limb. The main motive of this discussion in the limbs is so that I can discuss the nerves of the upper limb, because there will be question from the peripheral nerve injury. I mean, definitely, whether you say orthopedic question or the anatomy question, but there will be a question on the nerve injury here. So out of everything else, we need to mainly focus on the nerves, upper limb and lower limb major nerves. Abhi upper limb, when I say, obviously radial, ulnar, median nerve and musculocutaneous. Lower limb, it's mainly the sciatic nerve. So that's our main discussion that we have to do from here onwards. So how about I start with the radial nerve, and let's understand the different details. The nerve and nerve injuries are not difficult to understand. It's just that you need to remember the relevant detail here. If you try to remember everything supplied by the nerve, every single muscle named by the nerve here, then in the clinical question, that is not going to help you. That is going to trouble you, in fact. The easier way is look at the major things, and that will give you the whole idea that what the nerve is doing and what are the different features the patient will show it to you. For example, radial nerve. Videsh, EPB visibly prominent. Yeah, it is there. I mean, it is prominent. See, if you are able to see only one tendon, when you extend your thumb and you're able to see one tendon, like then you're most likely looking at the abductor pollicis longus tendon. Because extensor pollicis brevis is more inside, like to that here. So I'm pretty sure if you give you the picture of the anatomical snuff box, if it is a real-time picture, then they will give you a picture of a person whose like boundaries are very, very clearly visible to you, all 3 of them here, all 3 tendons. that's one of the reason कि I've generally seen the question is asked mainly in the lateral boundary of the snuff box, because lateral side we only have one tendon, extensor pollicis brevis tendon, longest tendon, sorry. So that's why there is no confusion on the lateral side. On the medial, on the lateral side, the medial side, I'm sorry, there is extensor pollicis longest tendon. That is no confusion. Lateral side there could be confusion because there are two tendons present. So that is why you got to be a little careful in that. If a stretched thumb is shown and you're able to see only two muscles, then you probably is looking at the extensor pollicis longus and abductor pollicis longus, because extensor pollicis brevis is more inside and it is not as prominent in abductor pollicis longus tendon. Radial nerve, guys, the root value for the radial nerve is C5 to T1. The whole brachial plexus contributes to the radial nerve, that is C5 to T1. And if I again tell you the major details, required details for the radial nerves, look, if this is the lower end of the humerus, and let's say this is the lateral epicondyle, the radial nerve goes from the axilla to the lateral side, and then it will be seen coming in front of the lateral epicondyle, and exactly in front of the lateral epicondyle it is going to UZ chair. UZ chair के तो सारे tendon visible होंगे, like not just the snuff box, I guess all the tendons. But having a UZ Chehel picture in the examination probably would be a copyright issue, so they might not give it to you, right? So you might have someone who looks like UZ Chehel, but not maybe exactly the UZ. So guys, so radial nerve in the axilla. See, radial nerve first is present in the axilla. Once it leaves the axilla, it goes into this radial groove or spiral groove. Here we have it. That's the radial groove there, right? Spiral groove or radial groove. Then you can see in front of lateral epicondyle. And finally, it gives off two branches in front of lateral epicondyle. One is a superficial branch, and the deep branch of this nerve, the deep branch actually becomes deep by passing or going through a muscle, and that muscle is supinator muscle. It is a supinator muscle. और जैसे supinator cross करेगा, the nerve will be running behind interosseous membrane. This nerve will be called as a posterior interosseous nerve. Posterior interosseous nerve. So guys, from the the nerve detail point of view, I just need to know this, that nerve starts in the axilla. As you can see, once it starts in the axilla, it goes into the spiral groove, comes toward the lateral side, in front of lateral epicondyle, or in front of the lateral epicondyle, it is going to divide into one sensory branch. Like superficial branch is a sensory branch, purely sensory, and posterior interosseous nerve is purely a motor branch. Now the question is, which main muscle is supplied by these nerves at this region here? Main muscle. Like again, you don't have to go into every single muscle. Like in the axilla, it supplies triceps. In the spiral groove also, it supplies triceps. So triceps muscle is supplied by the radial nerve in the axilla also, and supplied in the spiral groove also, tricep muscle. Then once the radial nerve comes toward the lateral side, it is going to supply the extensor carpi radialis longus, ECRL. And the reason ECRL muscle is important and needs a special attention, because it is one of the wrist extensor. It is one of the wrist extensor. One of the wrist extensor. Posterior interosseous nerve is going to supply all remaining extensors. All remaining extensors, guys. All remaining extensors, including one name which I am writing separately for you, that is extensor digitorum. And I'll tell you why I'm writing this name separately. That is extensor digitorum. Extensor digitorum. Whereas superficial branch is known for supplying the skin. And if I may very quickly draw it for you, what area of the skin is supplied by the superficial branch? If this is the dorsum of the hand, as I said, you don't have to draw anything because I'll be sharing these pictures with you. So if this is the back of the hand, let's say here's a nail bed, index finger, middle finger, ring finger, little finger. This lateral 3.5, except the nail bed area. The lateral 3.5, this area. Lateral 3.5 of the dorsum of hand, except the nail bed area, that is supplied by the superficial branch of the radial nerve. That's what superficial branch is supplying. Lateral 3.5, guys. No, dorsum of hand is fine, but lateral 3.5 and not the nail beds. Nail beds are supplied by median nerve in that area. So it's the superficial branch of radial nerve supplying the lateral 3.5. And see, if you know just these 4-5 details of radial nerve, no matter whatever question they will ask you on the radial nerve, you will be able to answer it. Like for example, if they, I'm saying 5 details. Detail number 1, radial nerve supplies triceps in axilla. You can see, check there. Radial nerve supplies triceps in the radial groove or spiral groove. Number 2. Radial nerve supplies ECRL above the lateral epicondyle. Number 3. All other extensors are supplied by what nerve? Posterior introitious nerve. And superficial branch supplies the skin on the lateral 3.5 of the dorsum of the hand. That's it. If you just remember these 5 points about radial nerve, you will not get a question wrong on the radial nerve. Let me prove it to you. The radial nerve injury, guys. When I talk about radial nerve injury, it can occur at different places. Radial nerve can get injured in the axilla, that is a crutch palsy. Radial nerve can get injured in the spiral groove, that is a Saturday night palsy. Radial nerve can get injured in the fracture or the injury at the level of lateral epicondyle. And there could be direct injury to posterior introsial nerve, especially in the radial head fracture. If the head fracture of the radius will be there, so that again could be involved here. So if I give them different cases, case A, case B, case C, and case D. Now look, what will happen, guys? Let me just take all these cases and write for you here. Now when you look at a case A, if the radial nerve is injured in the axilla, it's a very high palsy, it's a crutch palsy. Crutch palsy. Using abnormally long crutches can cause the crutch palsy, and that's how the radial nerve can get involved. That is a crutch palsy. Case A. In crutch palsy, everything supplied by the radial nerve is gone. Tricep is gone, all other extensors, superficial, kuch bhi kaam nahi kar raha, nothing is working. That's why, first of all, if tricep is not working, your elbow will be flexed. So you'll have a flexed elbow. If your elbow extensors are not working, your elbow will be flexed, so you have flexed elbow. If your extensors of the wrist are not working, so you have a wrist drop. So patient has a wrist drop. And not only wrist drop, guys, wrist drop is there because ECRL and other extensors are not working, but extensor digitorum, specifically the digitorum is also not working. So you not only will have a wrist drop, you also have a finger drop. Patient ko wrist drop bhi hoga or finger drop bhi hoga. Fingers are also flexed because extensor digitorum muscle is also not working. So it's not just the wrist drop, it's the finger drop also that you will see. And of course, there will be sensory loss on lateral 3.5 of the dorsum of hand. Now that is case A, that is the worst case scenario, that if the radial nerve is injured in the axilla only, as high in the axilla, everything supplied by radial nerve is gone. So your elbow will be flexed, your wrist will be dropped, your fingers will be dropped, and there is a sensory loss on the dorsum. The patient might be like, come to you in this position here. My elbow is flexed, my wrist is dropped, my fingers are also flexed, and there is a sensory loss on the lateral 3.5 of the dorsum of hand. Case B, how case B is different from case A? Well, this is the Saturday night palsy. Case B is the Saturday night palsy. Well guys, in the Saturday night palsy, what you will see, this time the only difference is that some part of the tricep will be spared, everything else is same. Everything else is same. The only thing is some portion of tricep is spared, and that will make the difference in case A and case B, because tricep is partly spared. Tricep is partly working, partly spared. So there is weakness in elbow extension. The patient will have a weakness in elbow extension. There is no flexed elbow, but there is a weakness in elbow extension. I do not have a strong tricep, so I have a weakness in elbow extension. And along with the weakness of elbow extension, rest everything is same. That means still have the wrist drop, we still have the finger drop, and we still have what loss? Sensory loss. Everything else is same. The only difference in case A and case B, in case A there is a flexed elbow, in case B there is a weakness in elbow extension. Okay, what about case C? Case C, when the nerve is injured in front of lateral epicondyle. When the nerve is injured, guys, in front of the lateral epicondyle, as you can see in the picture, now first of all, tricep is perfect, no problem. So tricep is working all right, so patient elbow extension is all right. So elbow extension is normal. This time, because the injury is at this point C here, so what muscle is also spared? ECRL is also spared. Ye bach gaya, guys. And because ECRL is spared, so this person may not have wrist drop. Weakness will be there, definitely weakness will be there, but there is no wrist drop. So he will not come with a wrist drop. Wrist might be like this only. But because extensor digitorum and other extensors are gone, so you have what drop? Finger drop will be there. So no wrist drop, but finger drop is present. And we still have what loss? We still have the sensory loss in this case. Still have a sensory loss. If the injury is here, your this nerve is still not working, your this nerve is not working. So you have a finger drop and you have a sensory loss. And there comes the final case, that is case D. Well guys, in case D, let me just shift it slightly above. Now what do you see in case D? This time it's the injury to posterior interosseous nerve, and it is usually because of the fracture of the head of the radius. Fracture head of radius. The Monteggia fracture. Fracture head of radius. And because of the fracture of the head of the radius, if there is a posterior interosseous nerve injury, the difference between case C and D will be that this time sensory loss will not be there because superficial branch will be spared. So the patient will have no wrist drop because still ECRL is and there will be finger drop. So only finger drop is there here. So in simple word, in the radial nerve injury guys, if the injury is in the axilla, flexed elbow, wrist drop, finger drop, sensory loss. If it in the spiral groove injury, Saturday night palsy, weakness of elbow extension and rest everything is same. Wrist drop, finger drop, sensory loss. If the injury is at the level of lateral epicondyle, then you only have finger drop and sensory loss. And if the injury is only to posterior interosseous nerve, then you only have finger drop, no sensory loss. So knowing this basics about the radial nerve, I'm sure that you will be able to fetch the answer to these questions, right? Yeah. So that's about the radial nerve and the different level of radial nerve injuries. I hope you understood this part. Chale, moving on to the next nerve, guys. The next nerve we'll talk about is the median nerve. Median nerve root value is also C5 to T1. The whole brachial plexus is going to contribute to median nerve. In the median nerve, the main focus is on the lower end of the humerus. Because median nerve and ulnar nerve also, they are not supplying anything in the axilla or arm. Their major supply is in the after the elbow itself here. So guys, when you look at the median nerve, you will see that median nerve first of all leaves the cubital fossa. The median nerve leaves the cubital fossa by passing between the two heads of pronator teres muscle. It is passed between the two heads of pronator teres muscle, and there you get the answer to that question also guys, pronator teres syndrome. Obviously the question says supinator syndrome. Supinator syndrome is posterior interosseous nerve, remember? If a question is about there is a supinator syndrome, so which nerve is getting affected? Posterior interosseous nerve. If the question says about the pronator teres syndrome, which nerve is getting affected? Median nerve. So median nerve is passing through pronator teres. And then what median nerve will do guys, it is going to supply the superficial flexors like flexor digitorum superficialis. It's a superficial flexor. Other superficial flexor also, I'm just looking at the main one. And there is a deep branch of this median nerve which is called as the anterior interosseous nerve. Look, posterior interosseous nerve was the branch of radial nerve. It's anterior interosseous nerve coming from median nerve. And this anterior interosseous nerve mainly is known for supplying the flexor digitorum profundus and that to lateral half of flexor digitorum profundus. Lateral half. It supplies the lateral half of flexor digitorum profundus. Then you will see the median nerve is reaching the hand by passing deep to the flexor retinaculum. It goes deep to the flexor retinaculum. And once it crosses the flexor retinaculum through carpal tunnel, it is a content of carpal tunnel. In the hand, it is going to supply the thenar muscles. It supplies thenar muscles. It supplies all thenars except adductor pollicis. It supplies all thenars except adductor pollicis. And it does supply first and second lumbrical also, L1 and L2. I'm just writing L1 and L2, first two lumbrical. That's a major supply of the median nerve. Again, as I said, I'm just looking at the main part here. We don't have to go into the extreme detail of that. So the nerve is going to cross the pronator teres muscle. Then it is giving off the branch to the flexor digitorum superficialis. And the anterior interosseous nerve supplies flexor digitorum profundus lateral half. Because it's a big muscle, it's a hybrid muscle. It is supplying the lateral half of flexor digitorum profundus. And once the median nerve goes into the hand, it supplies thenar muscles, except one thenar muscle, that is erector pollicis, supplied by ulnar nerve. This is supplied by ulnar nerve, and the first two lumbricals also. Once again, guys, if we talk about the injury of the nerve, the higher injury, lower injury. Two cases, if I say this time, that's case A here, and that is case B. Now, what difference do you see in both cases, and how are you going to differentiate them? Case A, when the nerve is injured high, at the elbow or even above the elbow, doesn't matter, it's the same thing only. If the nerve is injured as high as elbow, everything supplied by median nerve is gone. Now, first of all, median nerve supplies thenar muscles, guys. Thenar muscles are controlling thumb movement. And in case A, because thenar muscles are not working, so the patient will have ape thumb deformity. In median nerve injury, ape thumb deformity to hoga hi hoga. That will be there. Now, whether you have a higher injury or you have a lower injury, ape thumb deformity will be there because thenar muscles are supplied by the median nerve. So wherever you have injury to median nerve, one thing is definitely gone, that is a muscle, thumb muscles will be affected, and that will lead to ape thumb. Now let us say if I am your patient and I come to you with the ape thumb deformity, but you still don't know whether it is a higher injury or lower injury, because ape thumb deformity can be seen in case A also, ape thumb deformity can be seen in case B also. How will you differentiate between them? Well, very simple. You just have to ask the patient to make a fist. Now, to make a fist, guys, please understand this. To make a fist, I need to flex my fingers. Flexor digitorum superficialis, flexor digitorum profundus. These are the muscles which are required to make a fist. If the injury is higher at this point, then FDS muscle is completely gone. So there is no flexor digitorum superficialis working. And the lateral half of flexor digitorum profundus is also gone. But something is still working. Medial half of flexor digitorum profundus is still working. FDS to gone, guys. Flexor digitorum superficial, forget about it. That is completely gone. But in flexor digitorum profundus, the medial half of flexor digitorum profundus is by ulnar nerve, which we will discuss next. Ulnar nerve is supplying that medial half. So that means while making a fist, if a patient is making a fist like this, using these two fingers, or maybe using these three fingers, so we call it a pointing index finger, or we can call it a hand of benediction. Like different patient will have a different symptoms. That is an indication it is a higher injury. Because you are trying to make a fist, and because medial half of flexor digitorum profundus is still working, so you may be able to make a fist with these two fingers or sometime with these three fingers. If with the three fingers, then this patient is called having a pointing index finger, or if he is making a fist with two fingers only, we call it a Benedict's hand, hand of benediction. Both the cases are indicative of higher injury of median nerve. So thenar muscle, ape thumb deformity is there. And because flexor digitorum superficialis and lateral half of flexor digitorum profundus is not working, therefore there will be pointing index finger or hand of benediction, guys, pointing index finger or hand of benediction while making fist. While making fist, like not without making fist. When you ask the patient, otherwise you just see the ape thumb deformity only. But when you ask this patient with the ape thumb deformity to make a fist, and if you make a fist like this using these three finger or maybe using these two finger here, then it is an indicator of higher injury, right? So guys, in the higher injury case A, there is ape thumb deformity, and while making a fist, very important to say, while making a fist, if there is a pointing index finger or hand of benediction, that is indicative. Case B, guys, pretty simple. In case B, once again, there is an ape thumb deformity, but this time FDS and lateral half of FDP is working, so patient is able to make a fist. So if you see a patient who's having an ape thumb deformity, but is still able to make a fist, that means it is a lower injury of the median nerve, could be carpal tunnel syndrome. So in case B, once again, there will be ape thumb deformity. Well, no question about that. Ape thumb deformity is inevitable. That will be there. Ape thumb deformity. But this time because FDS and FDP are spared, wo bach gaye. FDP and FDP are spared. So you will not see, there is no pointing index finger or hand of benediction. I'm writing short, guys. there is no pointing index finger or hand of benediction while making a fist. So that's the two, broadly, that the two type of injury asked on the median nerve, higher and the lower injury. Elbow ke level pe hua, like pronator teres syndrome or anything, any reason for which a median nerve is injured here at this level, or carpal tunnel syndrome. Case B is CTS, guys. Case B is carpal tunnel syndrome. Then the difference in both the cases, there is eighth thumb deformity. In case A, patient is not able to make a fist with these two finger or maybe this finger, so pointing index finger or hand of benediction while making a fist. But case B ke andar the patient is able to make a fist here. So that's why you can differentiate between the case A and case B. There is higher injury and the lower injury of the median nerve. And finally, ulnar nerve. Just to finish off this discussion, guys, ulnar nerve. Ulnar nerve root value is C7, C8 and T1. C7, C8 and T1, that's the major root value for the ulnar nerve. Now for the ulnar nerve, what you will see, well, the prominent medial epicondyle, that's important. The nerve that is seen running behind medial epicondyle, that is the ulnar nerve. That is the ulnar nerve. बेटा आशिमा पेन टेस्ट में भी देखो, पेन टेस्ट में क्या करना पड़ेगा बच्चा आपको? पेन टेस्ट में if I'm holding a pen, I need to oppose my thumb toward this index finger and middle finger. The usual way of holding the pen is this, right? So in the pen test, if you are trying to hold the pen, if you already have a eighth thumb deformity, your thumb is extended, adducted and external rotated. आपको thumb ऐसे है. So pen test तो हो ही नहीं पाएगा. You will not be able to hold the pen. So you will be holding the pen like this, right? But if your thinars are working, if median nerve injury is not there, if the thinars are working, okay, then you will be able to hold the pen in this case here. There's another thing that I should tell you here, that if let's say there's a case of only anterior introitious nerve injury, main median nerve is working, but only anterior introitious nerve is injured, then flexor digitorum profundus muscle is affected. FDS is working, but FDP is not working, and these muscles are responsible for flexing the distal interphalangeal joint. So either it is holding the pen, or it is buttoning the shirt, or it is like making a OK sign, circular OK sign. That is only possible if you can do the flexion of the distal interphalangeal joint of the index finger and the thumb. If you can do the flexion of these joints, distal interphalangeal joint of index finger and interphalangeal joint of thumb, then only you can make this circular OK, or you can just make a O sign like this here. But if the anterior introitious nerve is injured, I cannot do this, guys. I cannot do this. So if you ask me to to make a OK sign, I'll make a OK sign like this. Flat OK sign will be there. So that is again an indication of that it is an injury to what now? That is an anterior introitious nerve. So if you have a case where there is no eighth thumb, deformity because the main median nerve is working. So thinars are working, so there is no eighth thumb deformity. But when you ask the patient to hold a pen or to button the shirt or to make a OK sign, circular OK sign like this, they are not able to do that because this joint cannot flex because FDP muscle is not working. And that's the muscle responsible for the flexion of the distal interphalangeal joint. So you'll make a OK sign like this, flat OK like this. Well, guys, ulnar nerve, the ulnar nerve is running behind medial epicondyle. Once the ulnar nerve, it crosses the medial epicondyle. Yes, Ashima. When we're doing this, we are checking for the anterior introitious nerve. Anterior introitious nerve is the one which is, because there could be the individual injury to anterior introitious nerve. Supracondylar fracture, there could be anterior introitious nerve injury alone. Rest of the median nerve will be working, but only anterior introitious nerve can be injured, and that can be tested by this. Okay, so coming back, guys, the median nerve, ulnar nerve, going behind medial epicondyle. Once the ulnar nerve comes from the posterior side of medial epicondyle, it will be seen passing between the two heads of the muscle, and this time the muscle is what? It's the flexor carpi ulnaris. Flexor carpi ulnaris, and the space between the flexor carpi ulnaris, it is called as a cubital tunnel. Cubital tunnel. So carpal tunnel syndrome, it was median nerve. Pronator teres syndrome, median nerve. But when the cubital tunnel syndrome, just be careful with pronator teres and the cubital tunnel syndrome. If the question says that is, it is a ulnar nerve palsy. It's higher ulnar nerve injury because flexor carpi ulnaris is giving passage to the ulnar nerve. That is called as a cubital tunnel. In the forearm, ulnar nerve supplies only this one muscle, that is flexor carpi ulnaris, and it does supply the medial half of flexor digitorum profundus. Flexor digitorum profundus, what half? Medial half. Only the medial half of flexor digitorum profundus. So not much, guys. Ulnar nerve is just supplying 1.5 muscle in the forearm. Just 1.5 muscle, 1.5 muscle. And then finally you will see that ulnar nerve is passing superficial to the flexor retinaculum. It is passing superficial flexor retinaculum, ultimately going through another canal which is present between the hamate bone and the pisiform bone, that is called as a Guyon's canal. It is running through Guyon's canal. And the ulnar nerve in the hand, ulnar nerve is the main nerve of the hand. It is the dominant nerve of the hand. Ulnar nerve in hand, it is going to supply the hypothenars. It supplies all hypothenars. That is a hypothenar बोले तो सब digiti minimi में सकते हैं. Flexor digiti minimi, abductor digiti minimi, opponens digiti minimi. So all the digiti minimi muscle, hypothenar muscle which are here. It does supply all interossei. So whether it is palmar interossei or it is a dorsal interossei, all interossei supplied by ulnar nerve. It supplies third and fourth lumbrical also. First and second lumbricals are supplied to median nerve, third and fourth are by the ulnar nerve. And guys, it lastly supplies the muscle called as adductor pollicis. The muscle is adductor pollicis. In fact, adductor pollicis is the last muscle to be supplied by ulnar nerve. इसलिए इसको graveyard of ulnar nerve भी बोलते हैं. This muscle is also called as a graveyard of ulnar nerve. It is the last muscle to be supplied by ulnar nerve, so we also call it a graveyard of ulnar nerve. So that's the ulnar nerve in forearm, just 1.5 muscle, flexor carpi annularis and the half of flexor digitorum profundus, and majority of the hand muscles are by the ulnar nerve. Now one thing is for sure, that whether you have a higher injury of the ulnar nerve or you have lower injury of ulnar nerve, whether it is a cubital tunnel syndrome or it is a Guyon's canal syndrome, there will be ulnar claw hand. Because first and second lumbricals are still working, guys. Third and fourth lumbrical are gone, interossei are gone. So because first and second lumbricals are still working, so it's not a complete claw hand, you have an ulnar claw hand. So you have a patient with coming like a ulnar claw hand is there. Ulnar claw hand will be seen in both the cases. The only question is that will you have a more severe ulnar claw hand if the injury is higher, let's say in case A, or will you have a more severe claw hand if the injury is in the lower part, let's say Guyon's canal syndrome, and it is opposite. It is ulnar paradox. In the lower injury, you have a more severe claw hand. In the higher injury, you have a less severe claw hand. And the reason is simple. The reason is this muscle, that is flexor digitorum profundus. Let's say if somebody is having a claw hand because the injury is here at this point B. So which muscle is still working? FDP is working. And working FDP means it is causing more flexion at the distal interphalangeal joint. So you already have a claw hand, imagine, और आपका FDP काम कर रहा है, guys. This working FDP will cause more flexion at the distal interphalangeal joint and looks like a more severe claw hand in this case. But if the injury is higher, if the injury is somewhere at the medial epicondyle, the claw hand is still there. But which muscle is also gone? FDP is also gone. And if FDP is not working, you cannot flex the distal interphalangeal joint. So that means your claw hand will look less severe here. So lower injury, more severe claw hand because FDP is contracting. Higher injury, FDP cannot contract. So we have a less prominent claw hand in that case. That is called as an ulnar paradox. So in the ulnar paradox, higher injury, less prominent claw hand, lower injury, it will be the more prominent claw hand. It is a more prominent claw hand, and this scenario of higher injury having a less prominent claw hand and lower injury more prominent claw hand, I'm sure you all know that is called as an ulnar paradox. It's a paradoxical situation. It's an ulnar paradox. Well, this is about the three major nerves, guys: ulnar nerve, median nerve, and the radial nerve, because they're very likely to get the question on this part here. So this is few things which I wanted to discuss with you in this part, anatomical snuff box, because the question being asked over and over again. This again question about the nerve injury to the humerus is being asked. There's a question on the tubercle. There's a question multiple time asked on the medial epicondyle, and medial epicondylitis, and the nerve injuries here. Few more things, obviously you'll be discussing them in the questions, in the form of questions with Dr. Nikhil in the revision part. Chalo. Dheeraj, you're asking, explain between complete claw hand and partial claw. But a complete claw hand is when the injury is to the lower trunk of brachial plexus, like in club case palsy. In clump case palsy, the lower trunk of brachial plexus is injured. Lower trunk of brachial plexus injury means the C8 and T1 root value is gone. अगर lower trunk को injury होगा तो C8 and T1 is gone. C8 and T1 is a root value for median nerve also and ulnar nerve also. That means all the muscles of hand will get affected. If the lower trunk is injured, then it's not just the injury to ulnar nerve. It is an injury to ulnar nerve also, and it is an injury to median nerve also, and that's why all the hand muscle will get affected. So this time the first and second lumbrical will also be affected. So the patient who's having a clump case palsy, they're all four lumbricals, all palmar interossei, all dorsal interossei will not be working, and that is why they have a complete claw hand. But when the injury is only to ulnar nerve and not to the lower trunk of brachial plexus, that means median nerve is still working, and median nerve is still supplying first lumbrical and second lumbrical, and that's why you will not see the claw hand most probably in these two fingers. So you have a claw hand like this here. So that's the difference between the complete claw hand and the partial claw hand. Sole ulnar nerve injury, complete claw hand. Lower trunk of brachial plexus injury, complete claw hand. Okay. Chalo guys, let me quickly move on to the next part. We need to quickly wrap up this session also. I cannot keep on going on and on in this. I wish that I would have taken the entire class for you, but yeah, right now it's a time for the revision. So let's go with the revision prospect only. And again, you have to keep the proper balance of how much of theory and how much of MCQ we're discussing, especially given that exam is in the July. So guys, let me move on to some of the lower limb part. This we'll discuss few of the things in the lower limb as well. So one question is about the identify ASIS, and again that's a question about ASIS, pubic symphysis. I've seen it multiple times. You people know more than what questions are being asked in the trend. So anterior superior iliac spine is asked multiple times. That's why I've kept a picture for that. And it's not just ASIS. They have been asking the question about the lesser trochanter and greater trochanter automatically is important because gluteal muscle are inserted on it. So there's a very fruitful discussion on this bone that I'll be doing with you. Navicular bone was asked in this picture, but I feel that navicular is not the only bone to be asked. Navicular, cuboid, cuneiform, there are few important bones to be identified in this picture that I will tell you about. Okay. This abnormal gait that I'll discuss along with this only, and that one main nerve that we have to discuss here is obviously the sciatic nerve. The sciatic nerve and the foot drop and all that is again a commonly asked question here. So let's go with that mindset. So I'm gonna start with this bone first. Okay. So guys, when you look at this hip bone here, well, the reason they keep on asking the question on this part, it's an important area, ASIS, anterior superior iliac spine. But because we're discussing ASIS, so why to leave AIIS also? There is anterior inferior iliac spine also. Anterior superior iliac spine is known for giving attachment to two important structures. One is the inguinal ligament. Inguinal ligament is attached to it, and it is the origin of the sartorius muscle. A very, very important sartorius muscle. And I feel that out of all the muscles of lower limb, the one muscle on which the question can be asked, especially about its action, is sartorius muscle, because sartorius muscle, it's more like an S-shaped muscle. So the way the sartorius muscle is crossing the hip joint and knee joint, so it is having a very specific action. Sartorius muscle on the hip joint, it produces the movement of flexion, abduction, and external rotation. You can remember Faber, like Faber-Castell Faber. So Faber, flexion, abduction, external rotation at the hip. And because sartorius muscle is also crossing the knee as well, so it is also causing the flexion at the knee joint also. So sartorius muscle is having a multiple function. At the hip joint, it is causing Faber, flexion, abduction, external rotation. Flexion, abduction, external rotation. And at the knee joint also, it is crossing the knee joint also, it is causing the flexion at the knee joint as well. But the anterior inferior iliac spine, it is giving origin to the muscle, and that muscle is the rectus femoris. The major part of the quadriceps femoris, that is rectus femoris muscle. Rectus femoris is also a two joint muscle. Rectus femoris muscle is crossing the hip joint and knee joint both in the front. If a muscle is crossing the hip joint from the front, it is causing the flexion of the hip joint, but it is causing the extension at the knee joint because it is in front of the knee joint. So this muscle again at the hip, it causes flexion, another flexion of the, but here's the important thing, at the knee joint, this muscle is responsible for the extension. Obviously quadriceps muscles are mainly for the extension, so is the rectus femoris muscle. The function of rectus femoris muscle is exactly opposite to the hamstring muscles. Hamstring muscle को उल्टा करते हैं guys. Hamstring muscles are responsible for the flexion at the knee and extension at the hip. They will cause the flexion at the knee and extension at the hip. Rectus femoris is a flexion at the hip and extension at the knee. So rectus femoris muscle and hamstring muscles like semitendinosus, semimelanosus, they're exactly opposite. They work exactly in the opposite way. Then another bony problem is, this is something which is asked twice in your exam. Twice in the exam in the last 5 years only, that is the lesser trochanter. Lesser trochanter. Lesser trochanter is giving attachment to or insertion to the muscle, and that muscle is iliopsoas. I'm using a blue color to show it because it's an insertion. It's a iliopsoas. Iliacus and psoas major muscle are inserted here, and iliopsoas muscle are also responsible for hip flexion. They are the major hip flexors, guys. They are responsible for hip flexion. These muscles basically will come from the front only. It'll come like one muscle will come from here, iliac fossa, one from lumbar, and the muscle will insert like this. So these muscles are crossing the hip joint from the front, so it's a major flexor. But the very interesting muscle here is the muscle which is attached to the greater trochanter, because there are questions on that. See, greater trochanter, one muscle which is inserted on the greater trochanter lateral surface is gluteus medius, and one on the posterior surface is we have a gluteus minimus. So we have a gluteus minimus and medius muscle insert. One is, in front of it, and one is on the lateral surface, not behind, in front and behind. So these two muscles both are inserted on the greater trochanter. Both these muscles are inserted on the greater trochanter, and these muscles which are inserted on the greater trochanter, guys, this muscle, what muscle are they? This we have a gluteus minimus and medius. Remember, not maximus. It's gluteus minimus and medius muscle. And gluteus minimus and medius muscle, what makes them so important? The gluteus minimus and medius muscle, they are responsible for the abduction and internal rotation at hip. Abduction and internal rotation at the hip. And that's why, because they're doing the abduction and internal rotation at the hip, so if you talk about the function of the muscle, let's say right gluteus medius muscle is causing the abduction of the right hip joint. But let's say when the left foot is off the ground, agar main left foot ko off the ground le lu, so it is also holding the pelvis as well. So if my gluteus medius muscle is not working because the nerve supplying it is not working or any reason, then there is a pelvic drop on the contralateral side. So if the gluteus medius or minimus muscle are not working, guys, there is an injury to the muscle, injury to the nerve supplying the muscle or whatever. If the muscle is not working, that will lead to the contralateral pelvic drop. Well, I'm sure you read about this. That is a Trendelenburg sign. Contralateral. Right side gluteus medius or minimus is injured, you have a pelvic drop on the left side. Okay? And in simple word, in Trendelenburg test or Trendelenburg sign, everything is ipsilateral except for pelvic drop. I mean, it's a right side muscle involvement, so I will say it's a right Trendelenburg positive. The patient will have a right side nerve injury. The patient will do the lurching also on the right side. When I'll walk, I'll lurch on the right side. But the pelvic drop on what side? On the left side. So just to keep it simple, in Trendelenburg sign or test, when we talk about the Trendelenburg sign or test, pelvic drop is on what side? Contralateral side. Baki sab kuch ipsilateral. Everything is ipsilateral. Nerve, muscle, right Trendelenburg sign, right lurching gait, everything is ipsilateral except for pelvic drop, which is on the contralateral side. So this is couple of things that from the osteology part, like they've been asking about this area. ASIS is asked twice in the exam. Lesser trochanter is asked twice in the exam. So you should know that what muscles are attached there, what structure attached there, unka function bhi kya hai. Because next time they might ask you the fracture of these bony prominences and what it can lead to. Okay, similarly, let me just tell you a little about the bones of the foot here, and let me classify the bones of the foot in two parts. See, when you look at the foot, obviously the highest bone over there is a talus. This is the talus bone. This is calcaneum. Look at this boat-shaped bone, guys. That is navicular. You got to identify these bone in radiological image also. Like that's navicular bone. And once you find the navicular bone, in front of the navicular, you have three cuneiform, out of which this is a medial cuneiform, intermediate cuneiform, and lateral cuneiform. Whereas the bone in front of the calcaneum is the cuboid. That's the cuboid bone. And then obviously looking at the metatarsal, there is a first metatarsal, the second metatarsal, the third metatarsal, the fourth, and the fifth metatarsal. So they have asked the question on the navicular bone, identify the navicular bone. I would say there's a couple of more important question to be asked from here. Like first of all, the second metatarsal, guys, there are two questions which I want to remember from there. Second metatarsal is the longest and most fixed metatarsal. It's the longest and the most fixed metatarsal, and that's why it is easily fractured. Well, I'm talking about the march fracture. You all know march fracture is usually a fracture of second metatarsal. Longest bhi hai or most fixed metatarsal is there. That's why it is easily fractured also. There is march fracture. For the stability of the base of second metatarsal, there is a special ligament present here. And that ligament is connecting the medial cuneiform to the base of second metatarsal. This is one of the neat questions, but I should tell you this. Guys, this ligament is called as a Lisfranc ligament. Lisfranc ligament is connecting the medial cuneiform to the base of second metatarsal. That's how exactly the question is asked. Which ligament connects the medial cuneiform to the base of second metatarsal? It stabilizes the base of second metatarsal. That is called as a Lisfranc ligament. That is a Lisfranc ligament. And one more thing that I should know from this area is that what are the bones contributing to the arches of foot, guys? So see, phalanges do not participate in the arches of foot. It's the first, second, and third metatarsal. All three cuneiform and navicular. All the three cuneiform and navicular. The whole talus bone, the entire talus, and the medial half of calcaneum. These are the bones of medial arch of foot. Now, foot is having one medial arch and one lateral arch. Medial arch of foot is having all the bones which I've highlighted in the yellow. And the fourth and the fifth metatarsal, the cuboid, and the lateral part of calcaneum are the bones which are contributing to lateral arch here. That is bone contributing to lateral arch. So this again could be a question to you that which bones are contributing to the medial longitudinal arch. So if the question is about the medial longitudinal arch, so we have total 9 bones present in it, the one which I've highlighted in yellow. But when it comes to the lateral longitudinal arch of the foot, well, not much. It's the arch with only 4 bones into it. Calcaneum we are counting on both sides, guys. We are counting the calcaneum both sides. So we have 4 bones in the lateral and we got the 9 bones in the medial longitudinal arch. And that's why the medial arch is the main arch of the foot. That is the major arch of the foot. Okay, let me also tell you a little about the question which is most likely to be asked in the exam, and undoubtedly that is the sciatic nerve and the injury to the sciatic nerve, and especially where the sensory fibers are running, like the sural nerve and saphenous nerve, where they are supplying on the foot, and how on the question basis, because they will tell you sensory loss yahan par hai, sensory loss is seen here at this place, and based on that you have to make out that which branch of sciatic nerve is injured here. Now guys, we all know that sciatic nerve is the largest nerve in the human body. This nerve is supplying almost everything in the lower limb except for anterior compartment. Anterior compartment is by femoral nerve and medial compartment is by obturator nerve, right? So anterior compartment femoral nerve, medial compartment by the obturator nerve, and rest everything is by the sciatic nerve. Sciatic nerve, let me start with that. The root value for the sciatic nerve is L4, L5, S1, S2, S3. It's L4, L5, S1, S2, S3. Let's do it this way, guys. The sciatic nerve, first of all, it is going to run through the gluteal region, and there is no supply in gluteal region by the sciatic nerve. Because in the gluteal region, we have a nerve called a superior gluteal nerve, inferior gluteal nerve. So, zarurat hi nahi, guys. So, there is no supply by the sciatic nerve in the gluteal region. After it crosses the gluteal region, the sciatic nerve goes into the hamstring compartment, and yes, it supplies all hamstrings. All hamstrings are supplied by the sciatic nerve. Semitendinosus, semimembranosus, biceps femoris, erector magnus, jitne bhi hamstrings are, all hamstring muscles are supplied by the sciatic nerve, no doubt about that. After it crosses the hamstring compartment, now the sciatic nerve goes into the popliteal fossa. This is where the main fate is decided. That fossa, there is a popliteal fossa, right? Let me just write that for you. So here is the popliteal fossa. And what you'll see that in the popliteal fossa, in the very much upper part of the popliteal fossa only, the sciatic nerve divides into two branches. One, you will see sciatic nerve branch which is continuing down straight. That nerve is called the tibial nerve. This nerve is tibial nerve. And then you will see a branch of the sciatic nerve which is winding around the neck of fibula. If I'm just drawing it slightly away, if this is a fibula bone, so it winds around the neck of fibula and then further divides into two more branches. Well, that's the common peroneal nerve. So this nerve here is the CPN, that is common peroneal nerve. So tibial nerve and common peroneal nerve, the two nerve. In the upper part, guys, in the upper portion of popliteal fossa only, they divides into the tibial nerve and the common peroneal nerve. Now, the common peroneal nerve divides into, one is a deep peroneal nerve and one is a superficial peroneal nerve, right? In the legs, we have three compartments. Three compartments के पास तीन nerve है. Tibial nerve, deep peroneal nerve, superficial peroneal nerve. If I may write this for you guys, tibial nerve, deep peroneal nerve and superficial peroneal nerve, they are basically supplying what compartments of the lower limb, of the leg. Tibial nerve is supplying the posterior compartment. Deep peroneal nerve supplies the anterior compartment, and superficial peroneal nerve supplies the lateral compartment of the leg. Compartments. Tibial nerve to the posterior compartment, calf muscle, gastrocnemius, soleus, plantaris, all that. Deep peroneal nerve supplies anterior compartment, all the dorsiflexors, extensor hallucis longus, extensor digitorum longus. And superficial peroneal nerve supplies the lateral compartment where we have peroneal muscle, peroneus longus, peroneus brevis. What I'm saying is, tibial nerve is mainly known for supplying what? Plantar flexors. Posterior compartment is having mainly what? Plantar flexors. Again guys, name of the muscle is not important. Function is important. अब वो चाहे gastrocnemius, whether it is gastrocnemius, soleus, plantaris, flexor hallucis longus, flexor digitorum longus, tibialis posterior, all of them are plantar flexors. That's important thing is they are plantar flexors. Deep peroneal nerve is mainly supplying the dorsiflexors, or you can say extensors, dorsiflexors or extensor hallucis, digitorum, all that. And superficial peroneal nerve, it is supplying peroneus longus and peroneus brevis, and peroneus longus and brevis are the everters of the foot. They're everters. In the leg, we have three compartments. We have a dorsiflexors, we got plantar flexors, and we have everters. There is no compartment for inversion. We definitely have inverters. Some inverters are present in this compartment, some inverters are present in this compartment, but there is no separate compartment for inverters as such. We have a separate compartment for plantar flexors, dorsiflexors, and everters. The question here is that if there is an injury to the the tibial nerve and common peroneal nerve, what will be the consequence? Guys, first, what is the fate? The tibial nerve, when it goes inside the foot, it is going to supply all the muscle of foot by dividing into two branches. One is called as a medial plantar nerve, and there is a nerve called as a lateral plantar nerve. Medial plantar nerve and lateral plantar nerve. Medial and lateral plantar nerve are the nerves supplying the muscles in the sole of foot. So sole of foot nerve is medial and lateral plantar nerve, that is supplying all the muscle present in the sole of foot. Whereas superficial and deep peroneal nerve, after supplying the respective muscle, they're basically going to supply the skin. And what area of the skin they supply, guys? Look, if I put this dorsum of the foot like this, yeah, this time I'm drawing the dorsum of the foot for you. The first web space, only the skin inside the first web space, guys, only the skin inside the first web space is supplied by the deep peroneal nerve. Deep peroneal nerve. Yes, guys, you're right. Foot drop will be the answer for this. But foot drop is not the only thing. What I wanted to understand, foot drop बड़ा common सा question हो गया. Foot drop is an important question, no doubt about that. Yeah. But what along with the foot drop will be seen? What will happen if common peroneal tibial nerve is injured here? So that's what I wanted to understand from this. So this area, the first web space is supplied by deep peroneal nerve. So the patient skin, the person's skin between the great toe and the second digit is by the deep peroneal nerve. Superficial peroneal nerve supplies the skin on the dorsum of the foot. The major nerve supplying the skin on the dorsum of the foot is a superficial peroneal nerve, except for medial margin and lateral margin. I'll tell you about that. So leave the medial and lateral margin and rest everything present on the dorsum of foot is by the superficial peroneal nerve. Right? What about medial margin, lateral margin? The medial margin is supplied by the saphenous nerve, which is actually a branch of femoral nerve running with the great saphenous vein. And the lateral margin of foot is supplied by the sural nerve. Sural nerve is a combined branch of tibial nerve and common peroneal nerve. It's a combined branch of tibial nerve and common peroneal nerve, guys. That is a sural nerve supplying the lateral margin of the foot. Medial margin of the foot, saphenous nerve. Femoral nerve का branch है. Thigh से आ रहा है. Femoral nerve का branch, saphenous nerve supplies the medial margin of foot. And the saphenous nerve, they generally talk about the saphenous nerve because it is running with what vein? Great saphenous vein. That's what makes it important. So if you take a graft of the great saphenous vein, saphenous nerve can get injured. If you take a graft from the short saphenous vein, I'm writing SSV, short saphenous vein, then sural nerve can get injured in that case. So that's the importance here. Okay, while taking a graft of the great saphenous vein, if you see there is a sensory loss on the medial side of leg and foot, that means saphenous nerve is injured. When you take a graft of the short saphenous vein, and if the patient feels a sensory loss on the lateral side of the leg and foot, that is because which nerve is injured? Sural nerve. So it's very important to know that great saphenous vein runs with the saphenous nerve, short saphenous nerve runs with the sural nerve. Sural nerve is a combined branch coming from tibial and common peroneal nerve. Though if you know this much about the sciatic nerve, we again will not go wrong in the questions. Look, presuming that you're not writing so that I can move on. So guys, if there is a tibial nerve injury, case 1, or if there is a common peroneal nerve injury, what will be the difference that you'll notice here? So case A is this, let's say, and this is the case B. If tibial nerve is injured, I wanted to notice on one thing, which muscles are gone? Plantar flexors are gone. And if plantar flexors are not working, the foot will be in what position? Dorsiflex position. So it's pretty simple. The case A is very, very simple, guys. In case A, it's a tibial nerve injury. And in the tibial nerve injury, as you can see, what muscles are gone? The plantar flexors are gone. Plantar flexors are not working, guys. Plantar flexors not working. So obviously foot will come into what? Dorsiflex position. It's a dorsiflexed foot. And dorsiflex, if a person walks with a dorsiflexed foot, what type of gait you expect to see in this person? It's a calcaneal gait, walking on heels. The gait is called as a calcaneal gait, that is walking on heel, that is a calcaneal gait. Walking on heel, that is a calcaneal gait. Like it's a dorsum foot like this, that is calcaneal gait, walking on heel. That is case A. That's pretty simple. Foot dorsiflex position hoga and the patient will walk on heel, that is a calcaneal gait here. About case B, in case B, it is a CPN. It's a common peroneal nerve injury. Now, in case of common peroneal nerve injury, guys, if you look at everything, first of all, peroneus longus and peroneus brevis are gone because superficial peroneal nerve is affected. So we know that these are the everters. If everters are gone, foot will come into what position? Inverted position. So we have an inverted foot. Number 1 is an inverted foot because peroneus longus and peroneus brevis are not working. So we have an inverted foot. Secondly, all the dorsiflexors are also not working. So you rightly said that will lead to what? Foot drop. If your dorsiflexors are not working, the foot is in what position? That is a foot drop position. So we have a foot drop. And this inverted foot and foot drop collectively, we call it a what? We call it an equinovarus foot. Guys, foot is equino. It is like plantar flex and inverted also. It's an equinovarus foot. Foot is in the position of equinovarus. Equinovarus. And yes, Dheeraj, you rightly said the gait in this case is a high steppage gait. It's a high steppage gait. You have to take a high steppage gait. The reason that a patient has to take a high steppage gait because the foot is in the plantar flex position. If you will not take the high steps off the ground, then your toes will be keep on dragging on the ground only. That's why the type of gait is what? High steppage gait. That is a high steppage gait is to be seen here. So it's not just about that asking the question on the foot drop and common peroneal nerve injury. They can ask you the question on tibial nerve injury also. They can ask you the question on that specifically which nerve should get injured, that only inverters will be affected. Everters will be affected. So everters will be affected if only superficial peroneal nerve is gone. So everters will be gone. Only everters are gone. If the question is asked, only dorsiflexors are gone, not the everters, then deep peroneal nerve is injured here. Tibial nerve injured, plantar flexor is gone. So what I'm saying, just don't try to stick only to the foot drop. That is an important question. Injury to common peroneal nerve at the neck of fibula, very, very commonly asked here. But again, they can put a little variation in the question, and also keep an eye on the sensor loss, because in the question they generally tell you about that patient is having a sensor loss somewhere. Like for example, it is, yeah, if you look at this question, guys, it says a patient presents with difficulty in the foot eversion and sensor loss on the lateral side of dorsum foot. Abhi foot eversion bhi nahi ho raha hai. The patient is not able to do the foot eversion because superficial peroneal nerve is gone. And there is a sensor loss on the dorsum foot because dorsum foot is also supplied mainly by what nerve? Superficial peroneal nerve. So clear answer to this question is superficial peroneal nerve. इसमें क्वेश्चन भी है सीजेरियन गेट. अभी सीजेरियन गेट में क्या होगा? Although this might be discussed in the questions with you by Dr. Nikhil, Caesarean gait, guys, it is because of the adductor tightness. If your adductors are tight, like if this is a normal person here, now if the adductors, the muscle inside, adductors are tight, so obviously your gait cycle will be like, you will be walking like this, Caesarean gait. Your foot will be more close here, and you walk like one foot in front of the other. Like when you see the models walking, they have like, they place one foot another in front of the other. That is, they don't have the this Caesarean gait because of the adductor tightness. But if there is an adductor tightness, that will lead to the Caesarean gait because of the legs will come more close to each other, and when you walk, your one foot will lie in front of the other here. That is called a Caesarean gait, and that is like it is written over there. That Caesarean gait will occur to the increased firing of which of the following? No? Well, Caesarean gait is because of the adductors, and adductors are all supplied by the obturator nerve. Medial compartment is completely supplied by the obturator nerve. That is all supplied by obturator nerve. Again, this is a question which I'm sure will be discussed with you in your question discussion part. Iliotibial band, guys. Iliotibial band is giving attachment to the gluteus maximus muscle, gluteus maximus, and tensor fascial lata, the two major muscles which are inserted, which are attached to the iliotibial band. What is iliotibial band? Iliotibial band is a thickening of fascial lata. Deep fascia of thigh is called as fascial lata, and this iliotibial band is giving attachment to the gluteus maximus and tensor fascial lata muscle in the upper part, in the gluteal region. Right, so guys, this is a part that I have planned to discuss with you. So we mainly focused on to the head and neck part, the neuroanatomy, the core area of the embryology, the upper limb and the lower limb. Obviously, there are questions asked from the viscera, the planes that you said, some of questions on the general part, but they will be covered in a way of questions with you. With Dr. Nikhil will be discussing certain questions from those areas, and I'm sure that those questions will cover up that remaining part here. But again, the dominant portion of your exam comprises of these topics, and you mainly have to emphasize on this part here. Right, so guys, I guess I've taken a lot of time of yours already. So we had these 3 sessions. Yeah, thank you, Abhinandan. I hope you people liked the session. I hope that this, I know that this is a revision session, guys. We cannot discuss everything in this, but I still hope that you people liked the session. If you do, please leave your comments. Like after the chat box is over, the comment box for the videos are open. So I would definitely love to have your comments and your feedbacks on that. And the moment I just close this video, within 10 minutes you'll find the PDF. As one of my comment will be the link of the PDF that I'm going to share with you, right? So you can download the PDF from there, and you can again go through these 3 videos that 3-part video that we've discussed. So I hope that this help you to revise the anatomy more efficiently here. So thank you, guys. Thank you so much. Obviously we still have the time, although I'm sitting in the opposite time zone with you, but now you people can always approach me. I hope you'll be knowing me through the Telegram channel or through the Instagram. So you can please inbox me if you have any queries or any doubt on any particular topic which troubles you. I might try to kind of organize a session maybe on the DBMCI channel or maybe on my personal YouTube channel, and we can obviously go into the detail of any query, any particular topic which concerns you. Thank you, Vidyesh, Janvi, Abhinandam, Mohan, Dr. Panda, Baba, Arjeet, Dheeraj. Thank you guys. Thank you so much for your listening. I know that there are a few people who are sticking to this session live, so thank you so much. And as I said, I'm just closing off the video, and the first thing I'm doing is I'm making a PDF, putting it into one of the Google site or whatever, any WeTransfer or something, and we'll put the link of that site in the comment box. So all the best, and yeah, well, I hope to see you on the other side. Goodbye. Take care.